Hi, and welcome to another ICS Impulse video. I'm Wendy Crumley-Welsh, the product manager for ICS Impulse. And today we're talking about the dynamic positional tests. Dynamic positional tests provide the ability to diagnose BPPV, or benign paroxysmal positional vertigo. The purpose of this test is to identify nystagmus that is evoked from dynamic changes in the patient's body orientation with respect to gravity, and thus diagnosing BPPV. Different positional tests are used to assess anterior-posterior canal BPPV or lateral canal BPPV. We are going to be talking about several different positional tests. We're going to talk about Dix-Hallpike, Hallpike-Stinger, and Roll. Now, posterior semicircular canal BPPV is the most prevalent. So, first one is Dix-Hallpike. This test assesses the anterior and posterior semicircular canals by recording the patient's eye movement during the maneuver. The ANSI standard, or American National Standards Institute, recommends that this test be performed with vision denied. I also want to mention that the British Society of Audiology also has a recommended procedure for the Dix-Hallpike. So the patient is sitting, and as we go through this, as I'm talking through how the test is performed, we're going to show you a video of a patient actually being positioned into these different positional tests. So the head is turned 45 degrees to the left or the right, depending on which side is being assessed. The patient is quickly laid back with the head slightly hanging off the end of the exam table. The patient's head is comfortably supported by the examiner during the test. According to the ANSI standard, the eye should be recorded for a minimum of 20 seconds in this position. And it's best to continue recording the eye movement until the nystagmus subsides. So you hold the patient down in this position until the nystagmus stops. Or if there's no nystagmus, you would record for a minimum of 20 seconds. Then the patient is brought back up to the sitting position, and again the eye movement should be recorded until the nystagmus subsides. The next test, the Hallpike-Stinger, is very similar to the Dix-Hallpike. So again, you would turn the head 45 degrees to the left, bring them down, or 45 degrees to the right and bring them down. What's different about the Hallpike-Stinger is that you have an additional position, which includes having the person centered, and you bring the head straight back towards the examiner with the head hanging off the edge of the table and the patient facing straight towards the ceiling. A third option is side lying. Side lying is actually a modified Dix-Hallpike. So you use side lying when the patient has a range of motion limitations or other problems precluding you to use the Dix-Hallpike maneuver. So again, this assesses the anterior and posterior semicircular canals by recording the patient's eye movement during the maneuver. So just like Dix-Hallpike and Hallpike-Stinger, side lying is assessing the anterior and posterior canals. The patient is sitting. The head is turned 45 degrees to the opposite side of the affected ear, so leftward or rightward. The patient is laid on the side of the affected ear, and the nose is turned 30 degrees in the opposite direction. So the nose is kind of turned up towards the ceiling. The next test is the roll test. This one is unique because it assesses the lateral semicircular canal, and again you're recording the patient's eye movement during the maneuver. You start with the patient laying supine, and you have the head tilted up 30 degrees. Then you quickly turn the head towards the affected side 55 degrees, or as far as it will turn to the left or the right, depending on which side is being assessed. So the minimum is 55 degrees, the maximum would be 90 degrees, but you want to turn the head as far as it will go to the side. So again, patients laying supine, you quickly turn the head to the left or to the right side. The patient's head is comfortably supported by the examiner during the test. The eyes should be recorded for a minimum of 20 seconds in this position. Again, it's best to continue recording until nystagmus subsides. Then the patient is brought back to the supine position, and the eye movement again should be recorded if any nystagmus is present until it subsides. Regarding pupil detection, calibration, or the vision denied solution, these are all covered in separate videos. Regarding goggle placement, you want to tighten the goggles so they stay put during the maneuver, but they do not need to be as tight as head impulse testing. You just want to make sure the goggles do not move during movement of the patient or the patient's head. Regarding the eye video recording, when you are doing pupil thresholding, you have the option of grayscale image or pupil location, but note that no matter which one you choose, the eye video will always be recorded in grayscale. And then head position feedback or synchronized room video. We're going to show you head position feedback, and the reason why that's bold is because that's what I think is most useful. The head position feedback will actually help guide you to make sure that patient is positioned at the proper angle. If there was a test that you wanted to perform that wasn't in this list, then I would use the synchronized room video to video the patient. And then the last two things, the external monitor and the presentation remote. So if you click this button, external monitor, you can then put the eye up on a big external monitor, which is helpful when you're maneuvering a patient leftward and rightward. You could have your laptop on one side of the table, a LCD monitor on the other side of the table so that you could monitor the eye. Again, you don't want to move to the next position until that nystagmus subsides. The other thing that'll be up on that external monitor besides just the eye video is the real-time SPV number. So that will also help guide you to make sure that you continue to keep the person in that position until that nystagmus subsides. The presentation remote, I think, is very helpful when doing positional testing. This allows you to start and stop the test without having to be near the computer. So it's just a simple little presentation remote. You can push the left button, right button to start and stop the test. So in test setup, you have the option of choosing different dynamic positional tests: Dix-Hallpike, Stinger, side lying, and roll. Then you have two options here: the vision denied. So are you doing this with vision or with vision denied? And then the next thing is torsional, and we're going to talk a little bit about torsional today. There is a video on torsional which will give you more information on how the torsional data is collected. But if you want to collect torsional for your dynamic positional, for example, for Dix-Hallpike, it makes sense to collect torsional since posterior canal BPPV is typically a torsional eye movement. Then you want to check the torsional box. Now know that torsional is a purchasable item. So it doesn't come with every system. So if you want torsional, then you need to contact your salesperson. So once you choose your test, then you'll choose your drop down. Do you want to do head left repeat, head right repeat? And then the capture button allows you to capture the reference frame for torsional. And again, that's covered in detail in the torsional video. And then once you have the region of interest set, you would click OK. So what's important is instructing the patient. So when you're doing a Dix-Hallpike, for example, and the patient is sitting up, a lot of times you want them to cross their arms across their chest. When you bring them back, you don't want them to feel like they're falling or flailing. So by crossing their hands across their chest, they feel a little more secure. You can also put one hand on their chest and one hand on their back when you're bringing them down, or you can just bring them down by having one hand on the head and one hand on the upper part of their back. But you want to make sure that that patient feels very secure. If they experience dizziness, they're already usually not feeling well. It's just a good idea to make sure that they feel comfortable and secure in their environment when you're doing the testing. So a couple of things is that for the head position feedback, you now have the center laser. So you can turn the center laser on, have that center laser aimed straight in front of them. If they are sitting up where you also do your head impulse testing, aim it towards the fixation dot, and then click center. So you make sure that that head is perfectly centered. Then when you're using head position feedback, which you see right here on the screen, it will guide you for the steps for each one of these tests and also shows you the canals that are being tested. When you start the test, you have two numbers up on your screen. You have a real-time slow phase velocity, which is telling you the robustness of the nystagmus. If that nystagmus is consistent, that number is green. If that nystagmus is inconsistent or that eye movement is inconsistent, that number is orange. So if the person has true nystagmus and they're not just looking around, then that number will be green. The next thing is head velocity. So how quickly are you moving that head back? So again, the robustness of the nystagmus, the ability to diagnose if it's BPPV or not, may be directly affected by, are you moving the patient back quickly enough. So you want to make sure you drop the patient back fairly quickly, and this number here is giving you the head velocity number. Now, at the present time, you may ask, well, what should that number be? And it's kind of a chicken and the egg thing. We are the first system to ever provide that information to end users. And so I believe that as more people use the software, then we'll have research coming out saying that this is a good head velocity or this head velocity is too slow. But right now we currently do not have that information. But that is available to you so you know what head velocity, how quickly you're moving that head when you move them from one position to another position. And then just so you know, the red trace is always your horizontal right and the purple trace is always your vertical right. So we're going to show you a video showing you the Dix-Hallpike maneuver and the head position feedback. The head position feedback we find is a very unique feature and very, very helpful to make sure that the patients are being positioned properly. And the other nice thing is then you can also play back that head movement as well as your eye video as well as your traces and your SPV graph. So let's show you a Dix-Hallpike first. You have the patient sitting up, have them turn the head 45 degrees, and then you bring them back. And the next one we want to show you is the Hallpike Stinger, but for this one we're just going to show you the bringing the head straight back because the right and the left are exactly the same as Dix-Hallpike. And then lastly, we want to show you roll. So the patient is supine with their head tipped 30 degrees, and then you move the head to the left or to the right 55 to 90 degrees. So you'll see in the head position feedback there's a block, and your ball just needs to be within that block. The top line, the upper line is 55 degrees, the lower line is 90 degrees. So let's talk about analysis, and let's actually go into the software and show you if you have torsional and if you don't have torsional. So this is an example of a patient with right posterior canal BPPV. And what you see here on the screen is the horizontal and the vertical trace. And then you have your SPV graph. So you see here there's a vertical eye movement, very little horizontal eye movement. And there was obviously a burst of activity, which is very common with posterior canal BPPV, and then the nystagmus side. And then when they were brought back up, you had a little more activity. So let's actually play this data so you can see what happens. And you'll notice the head position feedback as well. So there the head's turned. They're dropped back down. And then we see the eye movement. Now notice in the video, you can see that that eye movement is primarily torsional. It's turning counterclockwise. And then the eye subsides. So let's stop this and let's play it one more time. And look at that eye movement. So if you don't have torsional analysis, sometimes you can see the torsional eye movement in the video, but that's then just presence or absence. You can't really quantify that. Okay, let's hit stop. So in the info tab here, you see you have your horizontal trace, your vertical trace, and then your torsional trace. If you're looking at a particular point, then you will have that point information, and then here are the peaks for those three traces. So let's actually go in and look at that torsional data. So let's hit play again. And so here's the torsional trace, and you can see those beats of torsional nystagmus there. And then this peak of torsional nystagmus, there's basically about 6 degrees of torsional, counterclockwise torsional nystagmus. So let's play this again. So here, turn the head, bring the person back. And there you see the torsional nystagmus. And so the trace and the SPV graph look identical or are similar to the horizontal and vertical graphs. Similar meaning they're represented similarly. Obviously the data is going to be different based on if the eye is moving horizontally, vertically, or torsionally. So let's stop it and let's play it one more time. And we bring them back. So this is a right posterior canal BPPV. So it's just beautiful representation of data. So the other really nice thing about the OtoSuite vestibular positional module is its combination with AVOR. AVOR is a free app available on iPad and iPhones, so Apple devices. And it's a nice way to take your data, look at and set up the AVOR so that you're saying if you believe this is right posterior canal BPPV, bring your data in, look at your patient's eye movement to the predicted eye movement and see if they're the same. So there is an AVOR video to watch, and you can learn more about AVOR and the positional data. We've talked about the info tab. So you have point and peak information on the info tab. In the test tab, it gives you a list of all the tests that were performed on that patient by date and time. And then the reanalysis tab, if, for example, you had, so when you turn the head 45 degrees, oftentimes you'll get a little bit of eye movement. You can either choose to start the test, start the data collection after you turn the head 45 degrees, or you can take your cursor after when you're in an analysis, take your cursor, move it to after that eye movement has occurred, and then say analyze from cursor, and then you'll just get the eye movement that occurs after the head has been positioned downward. So everybody's eye is going to move some when you move their head 45 degrees, and you don't want to count that in your peak SPV analysis. If you want to delete a point, you can delete a point. If you want to reset the peak for any of the traces, you choose the trace here, horizontal, vertical, or torsional, and then you choose where you want the peak to be, and you just hit select, or you can restore back to the manufacturer's defaults. If you performed a positional test or repositioning test, a dynamic or repositioning test in the positional module, then that patient will have a checkbox in this column, so it's showing you the patient is being repositioned by that little icon there. So let's talk about interpretation. Abnormal dynamic positional represents peripheral dysfunction and is indicative of the presence of benign paroxysmal positional vertigo. It's a burst of nystagmus that is provoked by head movement, usually delayed in onset and subsides after a time. So delay, burst, fatigue. And that's why oftentimes you repeat the test to see did that BPVV or did that eye movement fatigue, because it will be weaker the second time you do it. And then direction reversal on sitting up. So when you bring the person back up, oftentimes their nystagmus will reverse in direction. Most BPPV is evidenced by torsional eye movement. So this is posterior canal BPPV is most prevalent. Horizontal canal involvement is less common and would result in horizontal nystagmus or purely horizontal if it's lateral canal BPPV. And this is commonly a unilateral issue. So the person will either have left or right-sided BPPV, not bilateral BPPV.